मेरे पास तो ये 70 वाला बढ़िया है। हाँ, बहुत है। 500 तो है।
Okay, Uttam sir, we can continue. We can go ahead.
Thank you, everyone, and hello, everyone. As you know, the SSPP every month we conduct some lecture or something. So this is our first session in 2025, and at the outset, I will like to wish you a happy New Year to you all. And
Recording in progress.
so today we are going to have something interesting, some interesting topic that about ozone. Ozone, everybody knows that it's a mysterious element, and I guess it has been used in every part of the body. You name it, intradiscally, intramuscular, intravenous, intraarticular. But that whether it's a weapon or in our armamentarium or it's a sham or just a placebo, it's $1 million question. So we have this good topic for debate today, and two eminent practitioners who will be debating on this topic. That too from two rival cities like Mumbai and Delhi. Dr. Dhruv Bibra from Delhi and Dr. Sidharth Verma from Mumbai. They don't need any introduction because they are well-known, eminent faculty in the pain. Dhruv is practicing in Delhi in Delhi Pain Management Clinic, and Siddharth is in DY Patil, and you must be knowing him through Mumbai Pain School, and he is having his own clinic as Panacea Pain Clinic. Am I right, Siddharth?
Yes, sir.
Okay. So over to you. First, I think Dhruv is going to talk. Okay.
Yes,
Over
sir.
to you, Dhruv.
For the motion. Thank you so much, sir. Thank you so much, sir. So I'll just make my slides. Okay. Are my slides visible? Am I audible? Am I seen?
Yes,
Any
sir.
feedback?
Yes.
Okay.
You can go ahead.
Thank you so much, the Pune Society, for giving me this opportunity, and thank you so much, Dr. Sanjog, for choosing me for the topic. When he introduced the topic to me, I was in Thailand, and Sanjog, I was attending a conference. So I was there, and he said, "Sir, ozone pe bologe," and I said, "Yes." When the official invitation came to me, and I read the entire topic, uh, I realized that the topic says a hidden weapon in the armamentarium of pain physician. Is it? Uh, I'm not able to change. Oops. अबे यार, अब ये क्या हो गया? Just give me a sec. पूरा build up इधर. Yeah. So is it really hidden? So let's find out. Thank you so much once again. And I really enjoy this kind of a format. I'm speaking in this kind of a format after some time now. And these kind of innovative ways make the topic really interesting and exciting. Is it really hidden? I don't think so. I think whenever we have interacted or whenever I have discussed, one of the most common things we have already discussed is about ozone. And over the years, starting in the world, it came in the, I think 1989 is the first recorded one, and there is some literature where they have used it in earlier also. Is it really hidden? I don't think so. We are using it. Only thing is the indications are increasing, and only thing which is making it more effective is now we have our own set of data. As lazy as we are as Indians, we have not printed it, so it is still not out in the open. Regarding our own journey in DPMC, because DPMC was started in 2005, so we started using ozone. It was one of the first modality that we started using in 2005, and Professor Dureja has been using it since 97, 98. Okay, now what has been the format? So people who are practicing, and we have a lot of people who are practicing pain, they will agree to my point is that every 3 months, we have a new kid on the block. Some new fancy stuff, some new name, some new intervention, which is introduced by the company people. This is better than this, that is better than this will solve your problem. And on paper, all of them seem to be very exciting, very interesting, and very promising. So whenever and then we discuss and talk about, so I have followed the same pattern. How do I approach whenever a new intervention is introduced to me? I have this 4-step approach, which I follow for all the interventions whenever they are first introduced. And for people who have doubts or who are thinking about using ozone, so let's try to follow, and hopefully they will get at the end of the day a clearer picture about ozone as a molecule. First is safety. That is paramount because I believe in the classical medical definition, do no harm. Then the potential benefits, what all things it can do, what are the indications, and as a true clinician, what has been our experience. Because on paper, some things look very beautiful, initial data is also good, but do they actually deliver in our subset of patients? So let's start with the very safety. Okay, so complications. So rather than talking at the last, I said, what are the complications? Potentially, if you go through the literature, right now I'm just going through the literature, my personal experience, I will be sharing it later. What are the complications? Either there can be, these are all enumerated. So whether you talk about slight irritation, increase in pain, or infection, all of them are procedure-related complication. None of it is a molecule-related complication. Right? So that is point number one. So and all of them with proper training, proper sepsis, and post-procedure antibiotic cover and NSAID cover, you can overcome all of them. So the point what I want to make is that it is an absolutely safe molecule. Now, I think because of the format, there will be talk about disc degeneration, cartilage damage, and things will be quoted from the literature. So the thing which is common is either they talk about excessive, improper use, or those data, that literature, I might be missing few, but it is mostly on animals, where they talk about that there are studies which talk about cartilage degeneration or disc degeneration, two are the most common things where we are injecting. Again, repeated injection, improper injection, any technology, any molecule in a, what should I say, not in proper hand, well-trained hands, is a potential threat. Right? So anything, everything done in a proper way is absolutely safe. So first things is that it is an absolutely safe molecule, and it has been proven time and again. All are procedure related complications which are there noted in the, which have been reported in the literature. None of them is significant. Absolutely no mortality and no morbidity. Step number 2, what are the mechanism of action of what all the benefits? Oxygenation is there, anti-inflammation, regeneration, and immunomodulation. And in fact, improved circulation has also been reported. So these are the basic things, how it works. Talking about the indications. Now, when we talk about the indications, we need to understand that now ozone over the period of time has the spectrum of conditions has increased. And therefore, now what has happened is now ozone can be applied or can be used in 3 types. One is a topical application, in which we just give ozone surrounding area, something like a non-healing ulcer. Second is when we are injecting it, when we are putting it inside some cavities and things like that, where we are either can be in a disc, whether it can be in a knee joint, it can be in a shoulder joint, or it can be cervical spine. So where we are putting it in a confined space. Third place where we are using it is where we are using it as in an IV formulation, IV or rectal, where it is being given systemically. Personally, I have got a maximum experience when we have tried to inject it in a closed cavity. Gradually, with probably with times to come, we might be going towards the IV formulations because there is a lot of talk about regeneration and rejuvenation and things like that. So there is ample data which talks about its role in low back pain, in herniated disc, both at the lumbar level, cervical level. Along with that, it is used in conditions of knee osteoarthritis and in even shoulder pain conditions also. Interestingly, there is another formulation, another way of approaching which has shown a lot of promise. This is something that we started doing it around 3-4 years back, where we were using ozone as a chlorotherapeutic agent. As we all know, it is an irritant which is injected into your body, and the tissue reaction helps in the regenerating part. So in the same way, we are using ozone. So rather than just going intra-articular, we also go peri-articular and try to inject into the various tendons. So therefore, even in patients of tendinopathies, ozone has a role. So now you have one where you have a contained space. Second, you have conditions where you are giving it peri-articular in the tendons and the ligaments, and the indications keep on increasing. These are the things for which there is literature which is coming up, where they talk about all kind of conditions. Personally, I have not used it, so I won't be talking about it. But they do talk about in patients of fibromyalgia, in which they say IV is very good, in chronic fatigue syndrome and things like that. But I would like to make this point clear that for the discussion and the format that we have, conditions of joint, peri-articular and intra-articular disc is the way forward for doing these interventions. Benefits: it is non-invasive or minimally invasive, minimal setup. So whether you are practicing in a metro like a Delhi, Mumbai, Pune, or you are practicing in Bhilwara, Chhattisgarh, Raipur, or any place, it can be done. Basic training for on the part of the person doing it has to be there, and it is absolutely safe in all age groups, all comorbidities, even in those patients who cannot lie prone for a very long time. So minimal, fast, quick, all are done in a daycare procedure, and obviously it is cost effective. Now this is something that everybody on the panel will agree that cost is one of the most common thing, and where we also at times get handicapped and we say, how do we help our patients? And in that scenario, this is a most cost effective for conditions like osteoarthritis or, for example, contained intervertebral discs. What has been our experience? So we started in 1997. So these are the indications. We have done it in intervertebral disc. We have done in knee OA. Gradually over a period, now we have started peri-articular also. Then shoulders, non-specific low back pain, where we have used as a chlorotherapy, non-specific low back pain, IV ozone therapy, very few cases, that too for Europeans, not for Indians right now, because he wanted something extra. Complications, I repeat, no morbidity, no mortality, no prolonged hospital stay, done in a daycare setup. Maximum it happens is that there is a temporary rise of previous pain symptoms. So that is something which is common with all intervention. Ozone is no exception. You are injecting an irritant substance in an inflamed tissue. So that will be taken care of. And then their vasovagal reactions are something which is common. So where would I be injecting? Now this is very specific. Where there is a recurrent disc with epidural fibrosis, calcified herniated disc, operated disc patients, spinal canal stenosis. So these are the structures where there is no point of giving ozone. And where it will help is, one, patient motivation. A patient has to be motivated to get better, good lifestyle, good exercise. All our intervention, irrespective of minimally invasive to highly invasive, the success is based on their motivation to get better. And second, which we will be talking and discussing in detail, is the intent of the interventionist, whether the interventionist wants it to be successful. So if the intent is there, patient is correct rightly, and as people who follow my talks would recall that I call famously the RR principle. Any intervention, right candidate, right intervention, right timing. If you get 3 right, then only your intervention works. This is the ozone machine. Now, one more thing which I think we will be discussing a lot during the subsequent session is standardization, quality of ozone. See, the point that is the biggest challenge, and now everybody would agree on that, that for any intervention that you have in pain, there are no very high quality studies. The reason being lack of standardization. The biggest challenge that we have with ozone is that people are not ready to invest in a good ozone machine, which is certified. So now we have got certain European certified machines also, which deliver good quality and predictable amount of ozone rather than the manual ones, which are where we are never sure how much ozone is being injected. Now, this is the procedure, simple daycare procedure. We go for the interdiscal approach and the center. Now, one more thing, people who would be doing it for the first time, it would be that it is a procedure for the nucleus pulposus. We are trying to dehydrate the disc. We are trying to shrink. So the needle tip has to be in the center. Regarding the knee also, the success of the intervention is based on the right placement. So whether ultrasound, whether a fluoroscopy, and also what we generally do is whether we are using ultrasound, whether we are using fluoroscopy, we always try to, dye is just for demonstration. We generally also try to aspirate a little bit of synovial fluid. Then we are 100% sure that we have hit the right target. Now, this is something which I've started using, but doing now is the posterior approach where we are doing spine. So this is just for that part. So these are our patients where we have done decent number of patients. So to conclude, I would say it is cheap, effective, safe, reliable, basic setup, basic training, and success depends on the right selection of the patient. And I think I would like to hand over the mic to Dr. Sidharth. And before we do that and get into this, I hope and I pray, as I would say, that this is a discussion where we are talking about the health benefits of an orange. Discussion should not go on whether avocado or kiwi is better or not. With that, over to you, Dr. Sidharth.
Thank you. Thank you, Dr. Dhruv. I'll just share my screen.
Hello.
Yes, I can hear you, sir.
Yeah. Sidharth, you can start. We can have a discussion after your lecture or fight.
There's no fight, sir.
लड़वा के मानोगे आप?
नहीं मजा आता है थोड़ा सा लड़ने में. चलो, over to you,
वही तो कह रहा हूँ. ऐसे
Just a minute.
मेरे बच्चे भी एक्साइट हो गए कि वो पोस्टर दिखाया ना, वो कहते सर आप पापा आपका बॉक्सिंग मैच हो रहा है. मैंने
बॉक्सिंग मैच
लैपटॉप में बैठ के बॉक्सिंग मैच थोड़ा हो रहा है.
लुक तो आपने बना लिया सर, बॉक्सिंग मैच ला रहे.
हाँ, मैं यही सोच रहा था ना, आपने एक पोस्टर में गलत किया. आधा मेरा रखते चेहरा, आधा सर का रखते, सिद्धार्थ का.
अभी देखो मैं ट्राई कर रहा हूँ, कुछ आएगा तो. अच्छा,
आएगा सर, आएगा.
देखो आया क्या? आया. अभी फुल स्क्रीन करेंगे, 1 मिनट. कितनी विंडोज हैं? Okay, just let me know when you can see this full screen. Yes, we can see the full screen. Okay, so thank you very much for giving me this opportunity and nice boxing image. But we are not going to box, we are going to just speak on facts and let the facts box either. So is it a hidden weapon or a weak link? And I will be speaking against the motion. And the whole purpose of the, or rather the gist of the talk which I'm going to give is going to be based on the fact that it depends on a personal preference, that whether you prefer science over speculation, or as pain physicians, our role is to advocate for evidence-based treatments. And ozone therapy, despite its very good appeal, uh, as elucidated by Dr. Dhruv, lacks the scientific rigor which is required for its mainstream acceptance as of now. So I will just focus on the current status and not on future stuff. So the first argument which I like to place is that there is lack of robust evidence as of now. There is very weak foundation in science. There is inconsistent study outcomes due to small sample sizes, and as Dr. Dhruv has himself accepted, lack of standardized protocols. There is a there are limited RCTs which are available, and if you see, there are lot many RCTs which are available now. I think I could find for the lumbar spine, I could find two even meta-analysis, and for the knee, I could find around four meta-analysis. And if you see the editorial commentaries in various reputed journals which have appeared after these analyses, you will come to understand that what is the real thinking or real analysis of the RCT. So if there is an meta-analysis and it gives you certain findings, you can't even blindly trust that. And there has to be certain criteria which you follow to make sure that your patients don't get a bad deal. So I'm quoting some papers. This one is an editorial commentary on medical ozone for knee OA. And if you see, there are a lot of evidence which is showing that there is poor quality evidence for its use. And you can see here in this particular paper, where although it will seem that they have given a positive recommendation, but you see there is the evidence which they have given is 2 3 2 1 1C, etc. And if you go for the limitation, they have given the lack of, again, precise diagnosis, that is poor quality. And there was no placebo controlled trial. There not even one placebo controlled trial was there. And you can very well understand that why the quality of evidence is poor and why it is excluded from most guidelines. There are good guidelines available now for spine treatment by various organizations. And if you see ozone therapy, although they have mentioned that it appears to yield positive results and it has low morbidity rates, as Dr. Dhruv himself mentioned, but what you should see is that this is the most of the evidence which is there. And criteria, you can see evidence obtained from diagnostic studies of uncertainty, and this is at least one properly designed small diagnostic accurately study. So this is what most of evidence is available for as of now. Now, if you see, there is a grading of recommendation which is there, and mostly it is 1C, which means a low quality or a very low quality evidence. In addition, I have some abstracts of some of the studies which have raised concern regarding its potential toxicity, and this is for the molecule as opposed to the procedure-related toxicity, which Dr. Dhruv spoke about. And I will just present some papers, and there is some heterogeneities in patient reaction hazards from all these oxidizing agents. And if it is actually mentioned in this particular very recent review which is available 2024, and even they recommend that until consolidated evidence emerges, clinicians should approach ozone therapy with circumspection. That is, you are yourself responsible for whatever any issues they are there, and the calibrating its use based on individual patient needs and clinical context. So if given a choice, and if there is any complications, you have to fend for yourself. This is what it means. There are a lot of demerits which they have listed in the same paper, and this, other than the standardized protocol and limited, which can be because of various reasons. One of them can be a poor machine also, but then for whatever reason there is not enough evidence, then you can see there is lack of insurance coverage for these patients. which actually brings it costly. So if I have another treatment which has insurance coverage, it's free for me. But if this one is there and I have to pay even like say 50,000 rupees or 30,000 rupees, that is too much. Then it is operator dependent, as Dr. Dhruv himself agreed that this is his experience, and maybe he's a very skilled guy, but then the success heavily relies on the expertise and skills of the operator. And of course there is a potential for ozone toxicity, and there is lack of universal regulation, which is, these are the features which they have put in their paper, but I have some additional ones which I will list on later. And if you see, the level of evidence is never, it's always two, and in many other issues or situations it is level 3 or even 4. So you can see for the chronic pain syndrome the level of evidence is poor, it is not very good. So uh, another thing which I want to emphasize is that there is a lot of safety concerns with this, where the ozone falls short. Not for intradiscal ozone risk, the biggest risk is discitis, which is a nightmare. I don't know whether any one of you has come across discitis, but if it happens to one of your patients, it's going to be really tough for you to defend. Nerve root damage is another one, and then the third one, which is very risky, is gas embolism. And this is a recent paper, 2024, of cerebral gas embolism and ischemia, which is a case report which is published. And mind it, for every one case report published, there may be many ones. Nobody reports their complications. So you should, be very careful while using the ozone. Then there is for the intra-articular ozone, infection again is a very big risk, and transient inflammation, which results after the injection can be considered. Then there are other older ones also which I could find, and there is even a cervical discitis which is actually rare, but people have managed to report that as well. So that is something. And ventral and dorsal root injury is also well known as per this particular reference which I have listed. Then you have limited and short term efficacy. That is what my third argument is, that it is not a very long lasting thing, as you know, and you think it is cheap, so let us repeat multiple times and all that, but then it is having a limited and short term efficacy. So I as a doctor will not like to put my particular situation at risk, and that is very important. So you will have a placebo like outcome. So I'm looking very nice, and I'm all dressed up, and all wearing nice suit and everything, and I just come and I do my procedure, and I come, and that bulb goes off, and I come out of the OT, and patients ask, well, how was the procedure? Yeah, it's very nice. And then even the patient feels 30% better, but that 30% is placebo. So the relief often mimics placebo effects. So if there is no placebo controlled trial, we cannot be sure. I told you there is not even one which I could find, and even one of the authors which has done this 2024 RCT, they say that they could not also find even one. There are no long-term benefits, and most of the studies they refer to around 6 months of time, which is very short for such a risky procedure. Then I think you can go to this original article from the World Neurosurgery, just 1 year old, February 2024, and you can see this one. And here they mentioned that internationally accepted treatment guidelines for lower back pain exclude ozone therapy. If it is so good, it should be included, right? Everybody is wanting to save cost. Everybody wants their patients to be better. Everybody wants a risk-free procedure. Everybody wants this. So why it is excluded? This should be the number one topic or hottest topic of discussion in most of them. Now let's come to the another argument that when there are better alternatives already there, why should I use it? For example, if I have a radiofrequency ablation, which I can consider for, which is backed by high quality RCTs, provides long-term relief with minimal risk. So why I should not do it? It is covered with insurance. So why I should not go with that? And then, for example, for disc, I can do an endoscopic spine surgery, which is targeted, effective, and ensures faster recovery. So why I should not do that, and rather get involved with something which is not having that high quality of evidence which is available, and risk my reputation as well as my patients' safety. In addition, there are some myths which I will like to debunk. ozone is a low cost solution. I think ozone low cost cannot compensate for the limited efficacy and safety risks which we are having. Ozone has minimal side effects. Fact is, documented risks include infection and tissue damage, so it cannot have minimal side effects. And it stimulates healing, so there is not even biological data which is available, like at the cellular level, some research or something like that. Although in each of the paper which I have read before coming to this debate, they say ozone does this, ozone does that, but then there is there are almost no biological evidence which is existing supporting this. So to just end, I will just say that for the verdict, just choose wisely. Don't put your reputation at risk. Innovation is essential, but not at the cost of patient safety and treatment efficacy. And we can do research in a research-based institution under we have registered a trial or something. But we must prioritize treatments like better treatments which are available and evidence-backed. And ozone therapy, in my opinion, falls short as a reliable weapon in our armamentarium. Thank you.
Thank you, Sidharth, for showing us so good evidences against this ozone therapy. As a student of Dr. Dureja, when I was in his clinic as a trainee, I have seen one patient coming on a wheelchair and going back on walking when he injected ozone. So that is one thing. Another side of this thing, when I used ozone in one of my case, and I used to do anesthesia that time, the same patient came for the discectomy a few years after that, and the disc was so hard that surgeon was not able to remove that part of the disc. So there are some pros and cons also. So just I want to ask Dhruv, whenever you are using the oxygen which is
Sir, we'll have a rebuttal first,
हाँ.
and then we can go for the questions. Now, Dr. Dhruv can go for the.
अरे सर, संजोग सर आपने और उत्तम सर आपने आपने सिद्धार्थ सर का टाइम क्यों किया वेस्ट? जब वही चीजें जो मैंने बोली थी, मैंने खुद ही बोल दिया, वही चीज को उन्होंने एक एक चीज को ही जस्ट आई ट्राई टू कट इट शॉर्ट टू सेव टाइम. ही गॉट दो सेम आर्टिकल्स विच आई वेंट थ्रू. तो आप मुझसे ही करवा लेते फॉर और अगेंस्ट. चलिए एक एक करके फिर भी देखिए, he talked about systemic side effects that is there when we are going IV. Secondly, he only said that it is operator dependent. तो आप खुद सोचिए, putting a needle in the disc is easy or high end procedures like radio frequency and endoscopy is easy. He talked about infection. Yes, infection is there whenever you enter a disc, whenever you enter a joint, whenever you enter anything in your body, there is a chance of an infection. Comparative to anything, this is the least invasive single needle thing which is going in. Patli hai, you can go through a needle in needle technique, reduce the infection. And one thing which I always tell, that disc and joint is a place of worship. So follow the sanctity of that area. ठीक है? रही बात, yes, there are no high quality evidence. Now the reason for it is lack of standardization. We do not have a standard good quality ozone machine what people are using. So that is the one biggest challenge which I do agree that if you have to do it, invest in a good machine. If you are investing in a good, if you are investing in a good Siam, please invest in a good machine so that you can get good results. उसके बाद long term, I talked about two things. One, patient's motivation. Any intervention can only work if the patient is ready to make those lifestyle changes and subtract a few things and add a few things. Second thing, sir beautifully talked about and literature about a study by the neurosurgeon which they talked about. I also covered that part. I said intention. this is a very simple example कि भाई वो मुझसे पूछता है मैं ये कराऊं कि वो कराऊं, तो मैं सिंपल बोलता हूँ कि मैं हल्दीराम हूं, मैं मिठाई बेचता हूं, मैं केक नहीं बेचता. केक रखे जरूर होते हैं बट इंटेंशन मिठाई बेचने की होती है. वही उनकी दुकान है भाई, वो बेकरी लगा रखे हैं, वो आपको काजू कतली और लड्डू पेड़े नहीं बेचेंगे. वो कहेंगे भैया केक है, मॉडर्न जमाना है, केक बेचो. So that is again one thing. Rest, sir talked about radio frequency. Radio frequency, the indications are different. We are not debulking. Yes, an alternative of ozone is endoscopic, but everything, right from all the complications that we talked about, 100%, the chances are more in endoscopy. Whether it is nerve irritation, whether it is discitis, whether whatever you talked about, हर चीज for all that things, the chances of infections in comparison to is more. We talked about insurance. Apart from surgical things, insurance is not covering anything. Gradually things are getting better, and if you put a word like discitis, they don't care what you put. So whether you put ozone discectomy or whatever, and I think people, I think Dr. Sidharth only told me कि ध्रुव तू यार discectomy डाल दे, वो दे देते हैं. So, yeah, so I think we covered, talking about cervical lumbar, वो है डिस्काइटिस है भाई. अगर आप ढंग से करोगे तो नहीं होगा, otherwise discitis will be there. And as I told, if you are aware, you can touch the nerve. That can happen even in a transforaminal. But if you are aware, patient is awake, you will not let you harm the nerve. And I think everybody, Dr. Uttam sir is senior to me, he will he will agree to me. In an awake patient, you cannot damage the nerve whatsoever. Regarding toxicity, one more thing. We are injecting in a disc not more than 3 to 4 ml. So if you are injecting 3 to 4 ml, the chances of systemic toxicity is absolutely nothing. There are no universities which are conducting these studies. So it is basically the private practitioners who are doing it. And because private practitioners are involved, therefore you do not have that volume of data which will be going again, which will be like backed by other therapies which we all know are heavily company backed, like for example radio frequency and this, right? And we have to understand the country in which we are living, right? So with that, I can assure you, with due respect to my senior colleague Dr. Sidharth, that it is an absolutely, I repeat, absolutely safe intervention if done properly. And be aware that these things can happen. Prevention is always better. Efficacy, as with all our pain intervention, is highly patient dependent. So before you put in anything, ozone, you have to motivate the patient कि भाई जिम्मेदारी हम दोनों साथ हैं. It is an equal responsibility. With that, thank you so much.
Thank you, Dhruv.
Over to Dr. Sidharth.
Okay, thank you. So first of all, I will talk about the motivation. अभी देखो, एक प्रोसीजर ऐसा नहीं है अपना जिसमें मोटिवेशन नहीं चाहिए, है ना. सो मैं कह दूं भैया आओ लेटो अपना काम कराओ, अपना पैसा दे दो, 1 0 बढ़ा दो मेरी फीस में, और फिर कल से कुछ मत करना. इट विल नॉट हैपन. सो मोटिवेशन इज ऑल्सो समथिंग विच इज यूनिफॉर्मली रिक्वायर्ड फॉर मोस्ट प्रोसीजर्स. देन सो दैट डजंट होल्ड ट्रू. सेकेंड इज इन्फेक्शन रिस्क. तो इन्फेक्शन रिस्क, अभी 4 ml हवा डाल रहे हैं भाई, ओजोन 4 ml of air generated through the best of the best generator, which is going to pass through a circuit, and there is a and then it is going to stay there, है ना. सो आप सोचो, अभी जस्ट इमेजिन, मैं आपको एक एग्जांपल देता हूँ. अभी कभी आप पीआरपी कर रहे हो हाँ घुटने में, एंड देन यू आर पुटिंग दैट, यू आर सीइंग इन अल्ट्रासाउंड एंड यू आर पुटिंग, और थोड़ा सा एयर बबल आता है, आप कहते ओ एयर आ गया, है ना. यू जस्ट गेट स्कैर्ड एंड ऑल दैट, है ना, एवरीथिंग. So you need to understand that 4 ml of drug you are putting it, let us call it a drug only, and you have to be very, very, very careful. And it is not only the bacteria which will carry from the skin, which can be of course minimized by various methods, as Dr. Dhruv has mentioned. And so it is not the infection risk which I am talking about, which is because of the usual one, that is the any percutaneous procedure. We are talking specifically about ozone, and the molecule related complication which was seen by intradiscal injection, and not by the the IV injection and what has been mentioned. So this you can study this case report which I have mentioned, and this is just one of the many which I have quoted. Next is, other than low backache and OA for the knee, there is actually very, very poor evidence, which I am very happy to use it the day somebody, comes in and, gives that evidence. Because let me tell you one thing. We are dealing with patients and who are educated and informed patients. Still everything is okay, everything is okay. If I agreement, हम दोनों साथ में हैं, उसने निभाया तो अच्छा है. अभी बात तो तभी आती है when they don't follow their part of the deal, like when some complication occurs. Now they will not agree. Now then you have to refer back to the literature. So personally, I am not going to take this much of risk unless I don't have any problem. Anybody for that matter, some private guy or some government guy can publish, and once it's published, it's okay. Other than that, all the treatments which I am going to use are going to be having at least some form of evidence which is there. It might be a different style, but that is how I would like to work. Then there was a talk about the cost effectiveness, which I think with the repetition and with the the duration again doesn't hold true, and the lack of standardized protocols. I am very happy if they are published. It is not only about the machine, but also about what are the indications, like how beautifully you have taught this. They should come in some kind of publication, and probably some cross verification should be there so that different centers can replicate these results. Other than that, I think I have mentioned everything. Ozone therapy, which is widespread, the use is widespread, I will say, but I agree, but that doesn't guarantee effectiveness. So validation must precede adoption, in my opinion, and there are many examples, like for example IDIT treatment, or there are many other hydrofusion which was there, and they were like very popular initially, but then they were proved ineffective or even harmful. So I think we should be very careful with that, and of course it prevents innovation, but that must be followed by some sort of evidence as well. And I will agree to Dr. Uttam's independent observation that the structure or the degeneration of the disc is affected, let me say, not say accelerated, but at least affected by any intradiscal procedure. So this also has a good effect, which significant impact, which should definitely be considered. So I will take it with a pinch of salt if all the evidence is disregarded and my patient has a complication which I have to face. Thank you very much.
Okay, thank you, Sidharth.
Before sir, thank
Anything
you
from
so
you,
much.
Dhruv?
Before we go with the docs, this was all in good gesture. No personal thing. If I have offended or I have gone bit personal, it is just for the format. That's it. Yeah.
Yeah,
लेनी
there is
धुनी
one
पूछ चुक
question for
माफ.
Dhruv, for you.
हाँ जी.
Dhruv,
हाँ जी. Yes sir.
I'm just asking the people that we are talking about the infection, discitis, and everything. When you are injecting ozone in the disc, do you use a filter?
Yes sir. I sometimes for this we use a filter. For knee we are not using a filter.
Okay.
Which kind of filter you use, sir?
Which
सर
kind
रेगुलर में आप जो एपिड्यूरल वाला आता है वही वाला यूज
अच्छा वही वाला यूज कर.
करते
Okay.
हैं and we don't inject more than 4 ml sir. That is again, and that is one. And second thing what I have seen is some of people who have discussed or been trained is that they go for repeated injections. That is not to be done. One, more than enough. If at all if it has to work, it will work. Otherwise, it won't work.
Even for intra-articular.
Yes, definitely. See, for intra-articular, you can repeat. So what I always say is that there has to be a significant pain relief for a significant period of time, translating into significant functionality. Right? Then only I repeat it. That is one. Second thing, for me personally, the relief has to be around 4 to 6 months. Otherwise, I would say, sorry, it never worked for you. Go for other modalities like whatever you have or whatever the patient can afford.
No, but for the knee intra-articular, sir, normally whatever literature is there or protocols are there, they are talking about weekly injections and 4 to 5 sessions and all those things.
नहीं, see, I generally, because going in, as we talked about it ना भाई, वो debate एक अलग बात है. You
Hmm.
cannot go inside the knee every week.
Yes.
Periarticular, like a prolotherapy, yes, but not inside the knee, never. And I
But
think Dr.
PRP
Siddharth,
regenerative also we are going weak. Some people are falling
but that
weakly.
is, they will be going for thrice. That's it. They will stop. But ozone is not, as Dr. Siddharth rightly pointed out, that there are a lot of factors which make, what you say, factors होते हैं जो infection को कर सकते हैं. PRP is still a better because the kit is closed and everything,
Yes. Yes.
right? So you cannot weekly nahi. Probably if it works, then later. That is one. Second thing is pure ozone is also. So I mix a little bit of steroid. What basically ozone has done on a very practical note is, for example, if the patient does not have for radio frequency or for PRP, so what it has actually helped us in our practice is we are able to cut down the dose of steroids if we have to inject into the knee. There are very few patients who are very, as Dr. Siddharth was telling you, who are learned and who just want, uh, what you say, ozone. That is the only subset of patients where I give ozone. But there also, I make sure that I mix local anesthetic at least there. And what rightly, yeah, so that is there. Yeah.
Siddharth,
Yes, sir.
yeah, if patient comes to you who is not affording having a disc, little bit of herniation, and what will be your choice then? If he is not affording for the any endoscopic procedure.
What level of herniation you are saying, sir? I mean,
See, right now, what there if there is no annular tear, we are
अफोर्डिंग नहीं है तो उसको उसमें कर देंगे ना, योजना में.
नहीं, see,
नहीं
सर
सर,
अपने
मैं
पास
मैं
हर एक
मैं
वही
जवाब
आता है
देता हूँ
सर.
सर. नहीं सर, मैं बताऊँ.
अप्रूव्ड है सर
In
वो.
that case also, if you are not comfortable या ozone के लिए, you give a epidural, sir, because there is some limited evidence for even for a discogenic pain for an epidural. So
So,
all this.
no, Dhruv, Dr. Dhruv, I will not agree to this. In fact, for axial low back pain, uh, steroid is epidural is now there is a negative recommendation for that. Um,
तो फिर क्या
for
करेंगे सर,
only if there
अफोर्डिंग
is
नहीं
no
होगा तो?
leg pain, they say don't use the steroid. If there is leg pain along with this, then definitely yes. But no leg pain, only back pain, like a pure, for example, patient comes and you have a characteristic pain of IDD. That is, patient sits for some time, after 15 minutes, pain starts. Then you characteristic symptoms. So probably those are not good candidates. But then definitely, if there is a leg pain, I agree, because then you will have at least some leakage, which
हम
is
कुछ ना
there.
कुछ तो होगा.
And I was regularly doing uh, intradiscal steroid initially, maybe from 2014 to 2017 when I stopped it, because I found that there was no difference between in the evidence also fell. Earlier it was like unequivocal, and later on it was almost coming to negative. But then I was also seeing that that time, I'll tell you one experience, that if I give the dye or the drug intradiscally, it will always come out. The vice versa may not be true, but अगर आप अंदर दे रहे हो, then if there is a leak, it has to come out. There is no other option.
but
So
anyway, if there is a leak, ozone is not. If there is an annular tear,
one
then
will also come out.
Yeah. So that is a contraindication. So the thing is, for any percutaneous blind procedure like ozone, the annulus has to be intact.
Yeah, so that
Contained
is
is
very
this.
important to mention here. So if you can, probably what would help is if Dr. Dhruv, you can come up with your whatever protocol is there, and you can circulate it to many people are doing. Tell them everybody teach यही करो, and then you will always have an evidence. क्या problem है? Unless if you don't want to share your secrets.
अरे नहीं सर, मेरा क्या है, मानेंगे नहीं ना.
मानेंगे क्यों नहीं मानेंगे? Definitely मानेंगे.
अरे नहीं.
yeah, I mean, there are few questions.
Yes sir.
How long it take for a patient to clinically better or wait for its results?
So 15 to the general standard protocol is what we say is for next 2 to 3 days there is going to be an increase in pain, which may last to up to 4 to 5 days. Effect starts coming in 15 to 20 days. So the first follow up is after 20 days. The complete resolution will take around 6 weeks to 8 weeks. अगर 6 to 8 weeks में कोई बहुत ज्यादा फर्क नहीं आया तो कहानी खत्म है, इट हैज नॉट वर्क, हाथ जोड़ लीजिए कि सॉरी इट नेवर वर्क.
Or according
And,
to
and
you,
and and one more thing, what people tend to do is, and sometimes doctor do not advise lot of bed rest. Guarded, gradual mobility is the thing. So they have to be mobile, but obviously more than routine activities are not to be done, but they have to be mobile, doing their regular stuff, self care, and all those things. So that has to be emphasized. What? Because what people do is they go on bed rest and come back with 80% relief, and then the next time they take a step and they have pain. So that is one thing, that mobility along with all these things have to be told to the patient.
there is another question. According to you, which ozone machine is good?
Now, the one which we had, it was a German imported machine. Now there are some other machines. I'll share it with the group, and Dr. Sanjog will be able to do, because there is a some I am no, World WIOF Federation, which in European countries it has certified the ozone companies and ozone modules models which can be used.
Yeah, because I just now I got a demo piece day before yesterday. Some Korean company, I guess, and
Hmm.
there is one vendor who is giving it for 35,000, and
Hmm.
one vendor is giving for 6,000. So
पांच
you
हजार की मशीन है सर, 5-10 हजार की मशीन.
हाँ, ये मैं दिखा रहा हूँ, यहाँ पे पड़ी है, मेरे बाजू में पड़ी है अभी.
नहीं,
So
यूरोपियन मशीन्स आर कॉस्टली सर. जर्मन मशीन्स एंड इटालियन मशीन्स एंड स्पेनिश, ये 3 कंट्रीज की हैं. दीज आर कॉस्टली. दे गो इनटू कपल ऑफ लैक्स. ज्यादा महंगी नहीं है, बट हाँ कपल ऑफ लैक्स की है.
और क्वेश्चंस क्या है अभी?
Recommend safe
What is the
volume.
recommended safe volume in the knee joint?
नी जॉइंट सर, अराउंड 10 to 15 ml. नी जॉइंट बड़ा है, 10 से 15 ml. नी और डिस्क के अंदर नॉट मोर देन एनी सर्कमस्टांसेस में 3 to 4 ml. जाएगा भी नहीं. इन द सेंस, पहली बात तो इट इज वेरी, यू वोंट बी एबल टू इंजेक्ट ऑल्सो. इवन इफ यू ट्राई, पीपल हु हैव इंजेक्टेड दे विल स्टार्ट फीलिंग द रेजिस्टेंस. So there is no need to do that pehlwani, and that is one. Second thing, be aware. Sometimes the MRI is fine, the what you say, everything. You will see that the annulus is uh, intact, but once you start injecting, the ozone will start leaking. So
And
you
what is
have
that?
to be aware that there has to be certain resistance, because you are going inside a closed cavity. There has to be certain pressure. So if you do not be aware that there might be a leakage, and there is no ego, I repeat, there is no ego in saying that I tried it, it was not successful, and you come out. Do no harm. I strongly believe that, yes, for a discussion and everything, but for any intervention which I always plan is, uh, I always say, do no harm. A concentration, how much we use, we are using around 30. That is why again I say that it is better to have an electronic one which is able to show, because the Indian ones that we have a lot of stupid ways of finding out whether it is working or not, because we have a
Dial.
good dial.
And what is your antibiotic protocol if you are doing ozone for the knee as well as in the disc?
No, in knee, sir, that's what I said. In knee, we are not doing any antibiotics. For disc, definitely a broad spectrum antibiotics. For we give a shot, we give a single shot IV, and then we do it for 5 to 7 days. Or एक normally you would see that we will not do, sir, you have spent time with sir. We do not go for blood tests. But in cases of where we are planning an ozone discectomy or things, we go for a simple CBC to just count whether there is some infection, or basically it gives us a baseline. Because sometimes what happens, there is an exacerbation of pain, and if it goes beyond 5, there can be a small degree of discitis. So if that case is, the first thing that you will go would be a repeat of blood tests, and then things will.
And how many discitis cases you saw after the ozone?
Sir, to be very honest, not boasting ourselves, but frank discitis, no. Where you could say that, where you have that a very tough time, the patient is in discitis, patient is not able to move. A classical discitis we have not seen. But what we have seen is that, on a very practical front, is that when the low grade back pain persists for say 10 to 14 days, 21 days, so that is a low grade discitis. That's what we have seen. Slight WBC थोड़े से बढ़ते हैं, CRP थोड़ा बढ़ता है, but gradually होता है. Simple antibiotics. We have been lucky that never knee, no knee, it has not happened, or disc. That's what I told. The only thing is the patient had low grade fever. We put the patient on bed rest, increase the IV antibiotics, and that's what we have been fine.
And what I have observed, if you inject some volume in the disc, patient do have pain for first 2 3 days. That
Yeah,
is,
that's def sir, that is there for any intervention. That is there for any intervention that you do, that there is going to be an increase in pain. Whether you do an RF, whether you do a PR regenerative option, whether you do a simple steroid also, there is going to be pain. Whether you do an alcohol, phenol, whatever, that is one thing which I, sorry, but because this is a platform, we can say that people say ना मैंने इंजेक्शन लगाया पेशेंट ठीक हो गया. वो नहीं होता है. वो लोकल का असर होता है, वो चला जाता है और 3 4 दिन दर्द होता है. इफ यू हैव हिट द टारगेट, देयर इज गोइंग टू बी पेन. This has been my experience. And people who say कि मैंने अभी कराया और 80% 90, it doesn't happen. And whatever, it is a false hope that it has worked. Yes, you have hit the target, but whether your intervention is going to work, that will only come to know after 15 20 days. वो इनिशियल पॉइंट ऑफ बिगनर्स लक कह लो या वो दो लोकल का असर कह लो, वो पीपल गेट एक्साइटेड, आई डिड दिस, आई दैट इज गुड फॉर फेसबुक एंड फॉर मार्केटिंग, बट ऑन रियल सिनेरियो, वन वन ऑन, इवन इफ आई से दैट आपने पिछली बार लगाया था, अब आप लगा रहे हो, या आपने मेरे पड़ोसी को लगाया था, अब क्या होगा, इट डजंट वर्क. आई एम वेरी श्योर दैट मैं पेशेंट्स, यू वर लकी फर्स्ट टाइम, यू मे नॉट बी लकी. Plan your day, plan your schedule in such a way, give me at least 7 10 15 days where you are going easy with your lifestyle.
so one last question from my side.
Yes, sir.
I will like to ask Sidharth. So this is not related to ozone, but just want to ask one thing. What about the radio frequency ablation? What is the evidence of RF ablation for trigeminal?
I don't remember on back of my this thing, but
It's but
just
but
very
there is no,
careful.
as far as I remember, in any literature they have not given that if the patient is with the MVD, the first and foremost thing is to go for the microvascular decompression.
No. The thing is, RF is the only procedure which has got in certain studies 99 or something kind of a success rate. The percentage, the highest percentage of RF
I
is
don't think so. We have
beyond MVD. If you see, I'm telling you. Now, what is a long lasting, where MVD scores is that they claim that it is a longer lasting procedure, but then the what proponents of RF, they say is that it has a higher morbidity. So what the agreement, general consensus is that if the patient is very younger age group, 28 30 35, so they say that you should go for a longer lasting procedure. That is the logic. And if the patient is like beyond 50 55 60, I have done RF in 94. So and with no bradycardia. So there are various ways in which we can actually manage it. And also the level of evidence is, it must be good. I'm not remembering it, but I think I can check it for you, because it is there in each and every textbook, each and every insurance, even in all yojanas. In the worst of the place, you will find RF trigeminal put there. So I think just let me check. You can continue talking, I'll just check in meeting.
So in all, to sum up the things, as Dr. Dhruv was saying, it's
Sir, I have two questions.
Yeah.
I just want to ask Dr. Dhruv, if patient is having multiple level disc degeneration, and so you do discography before your ozone injection to decide which levels to do ozone. So
Very
that is
good.
2 times putting needles.
Very
Or-
good question. उस पे ना बेस एक चीज, and then we'll go. See, the point is that you need to understand is that ozone discectomy is going to work in a well hydrated, acutely prolapsed disc. In a condition of DDD, which is a degenerative disc disease, it is not going to work.
Okay.
Right? Because it is already a dehydrated disc. उसका काम है, डॉक्टर उत्तम सर ने डायरेक्टली ही टोल्ड ना कि व्हाट यू आर गोइंग टू गेट इज अ डिहाइड्रेटेड डिस्क. तो एनी डिहाइड्रेटेड डिस्क व्हिच इज कॉजिंग अ प्रॉब्लम, ओजोन इज नॉट गोइंग टू वर्क.
ओके.
आई होप इट मेक्स.
तो बाहर हो गया ना सब, जितने जितने पेशेंट तुम्हारे पास आते हैं वो मतलब दे आर नॉट,
वो एंडोस्कोपी
हाँ वो ये नहीं आते
व्हाट
हैं
नहीं
तो
व्हाट
भाई।
एवर सी, वो
जो अपने
मैं
पास
उस पे नहीं
बच के आएगा वो दोज पेशेंट्स आर नॉट द आइडियल वंस, एक्चुअली द प्रॉब्लम इज देयर. I think somehow we are not getting the kind of patients which Dhruv is getting, so we should go and get
नहीं
those
नहीं
ones.
नहीं. डी देखिए, डी 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 के अंदर तो कुछ नहीं कर सकते. डी के अंदर आपको देखो क्या है. और देखो अंकल के एक्सपेक्टेशंस. प्रैक्टिकल फ्रंट पे तो पहले अंकल आंटी के एक्सपेक्टेशंस को गिराओ. उन्हें मंदिरों में जाना है, उन्होंने नीचे बैठना है, कीर्तन करने हैं, वो नहीं हो सकता. पहले तो कहो कि देखो जी, मैं आपको दर्द में कमी कर सकता हूँ. मैं जवान नहीं बनाने की मशीन है मेरे पास कि
वो
मैं
दर्द
अंदर
किसको
जाऊंगा.
करना चाहते हैं और आप उनको बिठा रहे हो. We
हाँ.
are our job is to put the patient back to work.
बैक टू वर्क सर, बट कीर्तन करने नीचे नहीं करो. मैंने कहा आप खड़े जाओ, आधा घंटा खड़े हो जाओ, पैरों को हिलाते रहो, परिक्रमा कर लो.
अरे बट
मैं
सर,
आपको
दिस
जैसे
दिस
जैसे जैसे फॉर
डीजनरेशन तो
एग्जांपल
आज
मथुरा में ना गोवर्धन परिक्रमा है. मैंने